slow and wait, you can't blame a doctor. People come to me, nobody blames. I give appointment, I can't honor it in 1 hour. They keep seeing me. Breakfast time gone, doctor didn't have. Lunch time gone, didn't have. When they walk in, agitated outside, they first say, please, doctor, have a tea, coffee. So they know the whole system is working, so people accept it in India. So if you go there, we do that. So slow and stressful. So stress keeps minding. Finally, they come to your face, just see me. Whatever it is, cancer, there or not, break the news, just allow me to go home. And this is Bangalore. So imagine you have to just come for one prescription of a calcium or a small dressing, or just to know that you are fine today. We just say come after 1 week, because I don't know, wound infection may happen, may not happen, everything is fine, but you have to show. So to do that act, what happens? So this is something very, very surprising. So who would need a home care then? So this is most important. Second, number of doctors, hospital for the patient, huge difference. So if you see abroad in NHS, there is a rule, this many doctors, this many bed, this many sisters, this much. In India, for every 10,000 patient, 1 bed, which means less hospital stay, more outside, please make that bed vacant for other people. So nowhere home care would actually be useful than anywhere else. This is something very, very important. Patient can save the time and money. They can have the comfort in home with the supported loved ones. It's medically known. As a surgeon, I always know that surgery is done early morning has got the best, because we know we have a biological clock. You have a surge between 5 to 11 o'clock, a hormonal, you have steroid surgeries, then are best. We know that. We don't tell the patient that nobody want to do it in afternoon. Similarly, we always know that it is not just a physical treatment. Mental health is directly related to a physical health. So you do with your loved ones in your home, the treatment outcome is totally different. In fact, I quite often do that. I see somebody is not doing well, some of them not passing urine, abdomen not doing, but I know they're stable. I just tell them, just go home, we'll monitor you in the home. They go home and come back, surprisingly things improve suddenly. I quite often do that. I don't have a medical reason to know why this patient is somehow not settling down, nothing acute. I consciously tell them that you just go home, one of our doctor will see, your home care will come. Invariably, believe me, I have never burned my finger. When they come back, suddenly something changes happen. I will tell you how home care actually made a difference. I made a paper on a robotic surgery and published. The commonest thing that came for me is, if you see that 16 days, 15 days hospital stay. I sent it to a top international journal. They told 12 days, 13 days stay for a surgery. Even bypass people don't say, but that's a fact. You do a rectal surgery in India or you do a major surgery, 10, 12 days, patient will just not move. They say stitch remove, drain remove. Who is going to go doctor with back, bust it will fall down. Who is going to see? And son says, I've taken 2 weeks, I am here. The moment I go, next day I have to go. I cannot bring. So keep him over here. I just cannot do. So this paper got so much of criticism, then I had to put it in Springer. I really learned the hard way. Then we had a home care mood in. I learned it very well. Now this time we did another trial in a gynae onco with the robot. If you see that it's in very small, I'm very sorry. See the average stay I had in the hospital, 1.94 day. This is because operate, next day I send the patient. The moment I know no complication, I tell home care is going to go home. Whatever medicines, injection, dressing, stocking care, everything home. So now I learnt it. So you can see how home care really changed. My paper became international standard level, sitting down in India in my hospital. And these two I published in international journal. So this is something which I say, we all know that whether we like or not, nosocomial infection is more. Everybody, those of you are surgeons or physicians, you would love to move your patient outside the ICU. ICU means suddenly you are not comfortable. You just go see and not very happy. Happiest news for a physician is your patient is going to come out. You just want to find a reason not to move the patient in ICU unless it is not life-saving thing. All is this, but I am more interested in the miscellaneous, which made my cancer patients actually sit very well. Now, is it really hype or did it make any difference? There are 2 parameters to see is your extended care in the home helping. Number 1, without home care, the average discharge in a major patient with home care, but that is not the essence. It is not pushing a patient home for statistics. What is the readmission rate? I told you a surgeon, when I was doing a training in thoracic surgery in Taiwan, least readmission rate, shortest hospital stay is a top surgeon. That is where the skill sits. So see, without home care, readmission, you think patient is fine, and then morning you had already declared discharge. Evening you say oral antibiotic, but suddenly evening notes you feel I need a injectable, but already you have declared, financially done, patient has brought the car, you just don't know. You would have otherwise preferred putting an injectable. With home care, readmission rates are very well. It's that bridging gap which makes the whole difference for us, which is very, very, very important, which is something. So especially another thing is, if you have end of life, that they don't need active, they don't want to go to hospice, but there is something in between. This is something which is tremendous. Nutrition management, back care, just giving an oxygen, or you want to give a pack or anything. So I least said more better than this. This is something very, very important. I have enormous amount of patient who has a end life care which is done in the home. In addition to all these things, physiotherapy, nursing, diagnostic, medical trained. You can underestimate, you know, diagnostic is so important. It is so important, I can't even tell you. One small investigation at the right time to be done. Patient says, I've got a burning micturition and a fever. I just say, okay, you need to give an urine for culture. I to just see the culture and put you. That act makes 2 to 3 visits to the hospital, plus they may not be able to see you because I'll have a schedule of operation theatre, then in the rounds. Simple home care collection and giving a report that comes on my WhatsApp of the phone, and I just prescribe the antibiotic and there is somebody to follow. So we'll split 2 things. What would be the goal in the home care in the health industries? Improvise the quality. See, just adding what you're doing has no meaning. It has to perfection level. You have to go to the next level. Quality of life should be more. You should add. Repercute it even from acute complications. Reducing the need for hospital. Palliative care when you can give. Don't have to visit just for the pain, prescription of a pain medications. Supportive devices and sustained independence from the hospital but dependence in the home. So what is the role as a physician, how we can really utilize? It's very important to identify who are the patients who need home care. Not that, oh, it is not one tonic made for everybody. It's very important to know elective surgeries. I clearly see who are going to help. Documenting a treatment plan, breaking that news to the patient upfront. Remember, people who embrace home care, I always tell them when I do a robotic rectal surgery, 3rd day I'm going to send you, don't worry about the stoma and drain, we are going to take part of it. They just know that they're going to, they would love anytime I say readmit, they say no, send the same staff and a doctor home, I'm very comfortable there. So this is actually all the physician role to really see how it actually helps and how we can actually help the patients. Initially, if you think the percent of the people who think home care, predominantly if you see 65, 2 to 3 things. Either they're no caretaker, they don't want to come, they're not ambulant. But if you see that now somewhere around 40, 50, second and third and fourth decade patients are also more and more utilizing it, which are the active people who spend in home. Where I use and where most of the time it is useful is, these are all the points. I will just put one across each other. Feeding is a most important point. Most of the people don't go. Feeding is not just nasojejunal feed, but a feeding jejunostomy. Nutrition is least expensive by enteral, but just to stay in the hospital costs 10 times more than the exact nutrition you give. It's like 10 times more than you do that. Very tremendously, you don't need a trained doctor, a very good health professional. Second, tracheostomy. Most of the people are damn scared about it. All you need is a portable vacuum and then somebody to educate them. So if you can just say, so for one tracheostomy, one attendant, one patient get tied up in the hospital and it's a chronic event. Imagine if you just say that I move in and we manage the tracheostomy in the home, it's a tremendous care. Stoma, there is a stigma. Nobody wants to touch. Everybody, all son, children, daughter-in-law, the person I always seen in my experience when I do a stoma, the person who is pushed to do that is a daughter-in-law. Son doesn't touch. Husband, very nice support. I always studied this. I as a doctor, is not just a doctor, I love studying human beings' mind. I always see who is it. When I always break a news, I will see how the people react. Immediately you know who is caring, how the son reacts, how the mother-in-law, how the son. Finally, I teach everything. Finally, daughter-in-law comes, sir, nobody is going to do, I am going to do, teach me this. They'll all listen, big thing. I just know that. So, you know, there is a social stigma. The moment you say, don't worry, a trained staff is going to come, change the bag, available all the time, round the clock, they're changed. Suddenly, the attitude is changed. They're ready to go home early. They're very happy, not staying in the hospital, putting a load on me. My doctor with me, DNB Surgical, is a post-MS working for 5 years. He's not wasting his time to changing the bag which somebody else require. Each time he changes in a bag, somebody else is where he's qualified specialist guy is required. He's wasting his time in the hospital. So if they move out somewhere, it's totally different. Second, I told you, you have done a joint replacement. I will just tell you how I got a home care. Second is, as an oncologist, I always believe it's crime to give chemo through the IV line. People only know that it's not the chemo, it's the IV access which causes the problem, and then if it exacerbates, you had it. Chemo stopped, the life is miserable, but I'm afraid. I put a port of 20,000, one infection, it is done. We have a trained staff in our hospital, in my cancer center. I don't allow anybody to touch. We have a 4th floor where chemo port patients go. Now I have a chemo port, so I cannot allow anybody to touch. They have to come down. My special trained sister has to access to give an antibiotic, draw the blood, or give, I'm not speaking about chemo, just drawing a blood for a count, or just putting a TPN or putting an antibiotic. Now imagine what we have done is we trained our pool of staff in Manipal hospital and they go home. As long as I know, all my ports patients, I do about 30-40 ports a month, they are attended by a chemo trained sister. Imagine what can be done. 3 monthly we do a flushing. They have to fix an appointment with me, they have to pay consultation, then they take a prescription, then they go to flushing room, they take a flush with an antibiotic, they go home. Half day 2 people, and imagine the cost. Now the staff goes, he does the same flushing for probably 500-600 rupees. It has revolutionized. Our people just love that. They never miss flushing now. Otherwise 6 months, 4 months they miss and chemo port is blocked and they're gone. I'm able to salvage. This is a tremendous care we had. And you know what we did? We didn't allow somebody who didn't know. Home care staff we trained, they worked with me for 1 month. I trained, my people went. It is like, you know, you are a doctor, you trust your system, but you don't trust somebody else. When you say, no, they are the best people, I would not trust unless it's my team. You may have the best junior doctor, but you want your junior doctor to see because you know the way you want to train. So what we did is, we took all the stoma people, they worked with us in the hospital, I trained them. The chemo port they trained and they went. So it is not just the comfort of the doctor and my own patient, but my own protocol people who went there. I discharge all my patients with multiple trains. 2-3 from here, 2-3 from here. You should see my patient while they're going home. I really wanted to get a photo, I didn't get it. So multiple tubes, people are amazed in India, you can convince those patients. I tell them, 5th day in Vipals, I know there is no leak, all tubes they go home, feeding jejunostomy tube, 2-3 tubes here. How do you convince? I just say I break it before. I just tell my patients say, no, I will not go. I tell them, from today morning, there is no IV injection, there is no IV medications required for you, no dressing required, no need to see me. Now it's only tube and drain care. To stay here, pay 10,000 rupees every day for 5 days and you may acquire some more infection. I may send you next week. You're poorer by 1 lakh and my doctor get tied up. You go home, all this what we do here will be taken care by my same staff who is trained. This is where I tremendously use the patient's care, doctor consultation, nursing, lab test. But remember, the most important part is, I used it. I wanted to see how I am a great auditor. I audit my result, I change my practice. I started a program called as a HIPEC, hyperthermic intraperitoneal. I did for 2 months, I stopped for 6 months. I thought I'm harming my patient more than that. Then I went back and observed and audited my result and then reworked where I went wrong. When I do a new technique, I do my work, I just gave. Like last 3 years I did a robotic esophagectomy, I didn't audit. You know that personal bias comes. I called my colleague Janardhan who is in general surgery, he took all the papers, he audited and told me what's happening right or wrong. So I wanted to now audit, okay, I am convinced what difference it made to me. So in cancer patients, we trained our own staff. I could never, I'm very choosy. You know that surgeons are egoistic, sorry, I'm a surgeon, and very touchy. This to be here, this close to be here, that sister only to scrub, that anesthetist, and 5-0 only, this suture. I also do that because you get into the group, probably all of them are contributing to your success when anything can go wrong. So you're very touchy, you're very possessive about your things. So I told my sister, so all the sister, I remember when Uday came, I told, I just don't know how they do, boss, forget it. We have a way of doing declotting of the drain, I don't know, I will not do. My doctors told, no, you'll never. So they were with us, I trained them. So okay, declotting sister, dressing sister, so they went trained. We personalized the treatment protocol.